Good afternoon, everyone, and thank you for joining us for this webinar, Joining Hands to Keep Kids Safe During COVID-19. This webinar is being co-hosted by the American Hospital Association, the American Academy of Pediatrics, and the Children's Hospital Association. I am your moderator, Dr. Roxy Cannon-Wells, president of Cape Fear Valley Hoag Hospital, and I also serve on the AHA's Board of Trustees. This webinar is part of AHA's Joining Hands for Greater Impact series, and it highlights how hospitals and health systems have partnered with their communities to respond to the pandemic. We would also like to note that this event was funded in part by a cooperative agreement with the Centers for Disease Control and Prevention. The contents of this resource do not necessarily represent the policy of CDC or HHS and should not be considered an endorsement by the federal government. It has been my privilege to partner with the AHA and CDC as a clinical ambassador with the goal of increasing confidence in the COVID-19 vaccine. Through radio news releases, media interviews, and other initiatives, our more than 40 ambassadors have reached millions of Americans with a positive message. Together, we help to inform individuals and families that the vaccines are safe and effective. Today's webinar comes at a particularly important time. As I am sure you all know, last week the FDA and CDC greenlighted Pfizer's COVID-19 vaccine for children ages 5 to 11. This recommendation is paving the way for children 5 and above to receive the vaccine. While this news comes as a relief to many families, many parents still have questions and concerns about the vaccine, and our hospitals and clinicians are trusted sources of information to build confidence in the safety of the vaccine for children. During today's conversation, we'll speak with leading pediatricians from across the country who will share their expertise and insights into the importance of vaccinating kids and will shed light on what it takes to foster parents' confidence in the vaccine. We will save the last 15 minutes of the webinar for questions. As your questions arise, please enter them in the Q&A box. We will respond to as many questions as we can. Now, I am pleased to introduce you to our speakers. Dr. Yvonne Bonnie Maldonado is the chief for the Division of Pediatric Infectious Diseases at Stanford University School of Medicine. Dr. Lee Savio Beers is a professor of pediatrics and the medical director for community health and advocacy at Children's National Hospital, as well as the president of the American Academy of Pediatrics. Dr. Elise Herman is a pediatrician at Kittitas Valley Healthcare, Ellensburg, Washington. And last but certainly not least, Dr. Andrew Pavia is the chief of the Division of Pediatric Infectious Diseases at Primary Children's Hospital in Utah. A hearty welcome to each of you, and we'll jump right in. Let's start with some introductions. Can each of you tell us about yourself, your hospital, and the patient population you serve? And if I may, I'll ask that we start with Lee, and then Bonnie, and then Elise, and Andy.
Well, absolutely. And thank you so much, Roxanne. And thanks for having us all here today. I'll actually sort of give two answers to that, one on the AAP side and then one on my own personal practice. I think you all know the American Academy of Pediatrics is the largest membership organization for pediatricians and is dedicated to the health and wellness of all children, adolescents, and young adults worldwide, really. And we represent over 67,000 pediatricians who really practice in a wide variety of settings, urban and suburban and rural, small practice, big practice, specialty, primary care. So I've been really grateful to have the opportunity to hear from pediatricians in so many different settings over the past year. In my clinical work, I work in Washington, D.C. in our primary care clinics associated with Children's National, the Children's Hospital, and take care of families, most of whom, mostly children who live in low-income families and are insured through Medicaid in Washington, D.C.
And thank you. Thanks for that great introduction. I'm Bonnie Maldonado, and as you heard, I work locally here. I'm the chief of pediatric infectious diseases. I'm also the head of infection prevention and control at the Children's Hospital. And I'm also a senior associate dean for faculty development and diversity at the School of Medicine. So a lot of my work is really intersecting around areas of health equity as well as infectious disease issues here. My clinical work is really primarily focused in the last year and a half on clinical trials on vaccines, in particular the pediatric vaccines, the Pfizer trials, and also working on antiviral studies in our outpatient clinical trials evaluation unit, but also overseeing my faculty, their clinical services, COVID and non-COVID in the hospital. From the national perspective, I've been working very closely with Lee and other colleagues with the American Academy of Pediatrics, primarily in my role as the chair of the Committee on Infectious Diseases, affectionately known as the Red Book Committee. So I've been working on that committee for several years now, and have been participating in all of these wonderful activities that the Academy has been sponsoring regarding advocacy, education, and communication across all of our stakeholders. Thanks.
And I'm Elise Herman. I'm a general pediatrician in beautiful Ellensburg, Washington, which is a rural community on the east side of the Cascades in Washington state. I've been here for 31 years. The first 28 years I was in private practice. And then 3 years ago, I joined our local hospital healthcare system, Kittitas Valley Healthcare. That's been a great change. And it's a small town, 20,000 people. Our county is 48,000 spread out over more than 2,300 square miles. We're rural, and our hospital is the only one in the county. We're the only pediatric clinic in the county as well. Our hospital system is KVH plus about 15 outpatient clinics, as well as other services, physical therapy, et cetera. Our makeup is largely white, largely Caucasian, with smaller populations, Hispanic, Asian, and Black populations. And it's been a very interesting year and a half with the pandemic, especially being a general pediatrician in a rural community. So I'm honored to be on this panel. Thank you.
Hi, so I'm Andy Pavia. As mentioned, I'm Chief of Pediatric Infectious Diseases at the University of Utah and Primary Children's Hospital. By way of background, I'm an epidemiologist trained at the CDC. Have to admit that I also had a detour into internal medicine, so I'm med-peds trained and not just a pediatrician. Our hospital is the only referral hospital for a 4-state area of over 10,000 square miles. So we serve children from the Salt Lake regional area all the way out, really up to the Canadian border and well into Arizona. And that gives us a wide diversity of children that we serve, but also the pediatricians we support throughout the region. And we spend a lot of time doing outreach and education. I've been interested in viral diseases and emerging infections for a long time, and been working on pandemic preparedness for 20-something years, which of course was no preparation for what we've been through, much as we thought it would be. Also was privileged to serve on the National Vaccine Advisory Committee for a number of years, where I chaired a working group on vaccine safety, which I think is pretty relevant to what we want to talk about today. So I'm glad to be here.
Awesome. Thank each of you for sharing your backgrounds and your information. I know that our audience is going to receive a lot of great information from each of you, and I'm really excited to be here with you. We'll go ahead and start, and I think I'll pose the first question to Dr. Maldonado. You're an expert on pediatric infectious diseases. Can you share a bit about where we are with the COVID vaccines for pediatric populations, especially since you've had a big hand in developing and working through the development of it? And how did we get here with where we are today with the vaccine?
Well, let me just say, first of all, that I really think it is nothing short of astounding that less than 2 years into this pandemic, not only do we have highly safe and effective vaccines for all populations, but that we were able to get safe and effective trials in children for vaccines. So that's really, I think, historical. We've never seen a vaccine candidates move ahead this way. And I've never been involved with an industry-sponsored vaccine study myself, because that's not the kind of research I do, but I really felt an obligation to be able to participate in an industry-sponsored trial to see what the mechanisms were, how transparent the companies were with data, how they were engaging families. And in our community, which I didn't mention earlier, we have also our county is one of the most diverse counties in the United States. So we certainly serve a lot of underrepresented populations and really wanted to make sure we understood the process. And so far, we've been very excited about the industry ability to really step up and try to address issues of equity. The vaccine trials have been really very well run. And what we've seen, as you heard, is high safe and effectiveness and efficacy data in children and adults, as well as now in children. And we've seen full licensure of the Pfizer vaccine, meaning full approval for people 16 and older in the United States. And that just happened earlier this year. And for children 5 to 15 years of age, we have emergency use authorization based on very robust data on safety and efficacy. And we're anticipating that we will have applications for full approval for those age groups in 2022. We are also still working on hearing from Moderna and Johnson & Johnson vaccines for people under 18 as well. I don't know when those data will be available, but more likely in 2022. But at least we have one vaccine available at this point, and we hope there will be others. And then finally, we're currently working on studies for children under 5 as well. Those studies, we're really moving along at a reasonable pace, but really trying to get the older children studies finished. So we're hoping again in 2022 that there will be vaccines available for children from 6 months of age forward. And again, the FDA and the CD processes have been very transparent. I think everyone's been able to see them online for free if they want to. The documents are all posted. And many of us who are pediatric infectious disease faculty and practicing pediatricians around the country have really had access to data for, again, as I mentioned earlier, communication and advocacy. So we are really excited to see this because children do get infected, and we've seen, we'll talk about this later, I suspect, but this disease does impact them directly and indirectly. Thank you.
Thank you. Thank you. I appreciate the work that you have done and others have done to ensure that we actually, as you stated, just under 2 years, we've been able to really pull together an answer for this virus. And it has been a phenomenal 2 years. So thank you very much. Dr. Beers, as president of AAP, can you speak to how AAP is working with pediatricians to build confidence in the vaccine? How can pediatricians and children's hospitals support the rollout as 5 to 11-year-olds become eligible? Would you share your thoughts on those questions?
Yeah, well, absolutely. And I think first I'll as well echo what Dr. Maldonado said is this just really is remarkable. And I think this is, it's such an important milestone for children and families and for us as pediatricians. And I think one of the things that we have really worked to do as the AAP really throughout the pandemic, even actually before the vaccine was authorized in adolescents or in our younger children, is a couple of different things. I think, first is, and Dr. Maldonado, you mentioned this, access to information and transparency and education is really important. And, I think pediatricians across the country, or all of us, right? It's helpful to have a place to go to have all that information in one place. And so we've done our best to really try to get that information out there so that our practicing pediatricians really could have the most up-to-date information. So there's written materials, there's materials on our website. We host, and Bonnie and I have done these together many times, town halls every other week, where our experts come together and just talk about the latest information and the latest data and give some context to that. And so lots of that. I think the other thing that we've been working on actually over the past several years that relates to vaccine confidence in general is recognizing that actually vaccine hesitancy and sort of anti-vaccination sentiment has been rising over many years. And so we've been working with a group called Frameworks to really help dive into that and help to think about what the most effective communication is around vaccines so that we can really engage in good dialogue with families. That report actually, that's ongoing work, but we some of that has come out recently. And then I think we've been working on some external stuff too, knowing that this is about communication between pediatricians and families, right? And so we want to be able to help open the door for those conversations. And so we've created a number of PSAs, different written documents, handouts that pediatricians can use or that families can go to our healthychildren.org website and use. We have some brand new that I'll share if you guys don't have them, explainer videos, so these sort of animated videos that explain how the mRNA vaccines work. And they're really terrific, actually. So that kind of thing. And then just in terms of how everyone can help and work together, I think so many different things, right? You can be vaccinators or vaccination sites, connect to other places in your community that are doing vaccination, providing education, helping to facilitate and develop partnerships to increase confidence, partnerships with community-based organizations or faith-based organizations or schools. So I think those are all different things that as children's hospitals and as pediatricians that we can all, and actually every hospital system, we can be doing together.
Thank you. I think as you stated, families have a wonderful connection with their pediatricians, and you all have done quite a bit of groundwork, and even prior to the COVID-19 vaccine, and ensuring that parents understand the need to vaccinate children. And so I think having done that work is going to be very helpful moving forward. As practicing pediatricians, given that we have vaccinated children 12 and above, I'm interested in what your experience has been with the COVID-19 vaccine and kids so far. And I think I will pose this question to Elise and then Andy and finally Bonnie.
Yeah, so as a pediatrician, I have been chatting with families about vaccines for over 30 years, and there has been some vaccine hesitancy, but as was mentioned, things are a little different with COVID-19, so a little more hesitancy, a little more questioning, so those conversations can be a little more tense. So in general, I do recommend if the child's eligible for a vaccine, I am enthusiastically recommending it, but then I also ask the parents, what questions do they have? What have they heard? Do they have any concerns? And really try and make this a conversation. So I listen to what they have to say, and then I've learned to ask permission to explain what I've heard and what I've learned. And I also empathize that there's a lot of information out there. And of course, there's a lot of misinformation. It can be very confusing for parents. And we really try and come together over the joint concern that we want what is best for their child. I always emphasize the safety and the efficacy of the vaccines, and I do speak to their concerns. And typically what people are telling me is they're concerned that the vaccine trials and research was too rushed. They're hearing concerning information about fertility and then the issue of myocarditis. So with their permission, I walk through those, particularly talking about how the vaccine trials were done, that there were no shortcuts. And so we kind of walk through it together. I do lead them to the website, of course, American Academy of Pediatrics. The Washington chapter of the AAP has a lot of good information, and also the CDC. So try and get them to look at those resources. And then I I'm in a small town. I write articles for our local paper, and they also go on about pediatrics on our local website for the hospital. So I've been writing these articles for about 10 years. Lately, they all seem to be about COVID and kids. And so I have some articles that are pretty brief that are about COVID and children, and then COVID vaccination in children. And I just updated one today that's specifically for vaccination of kids age 5 to 11. So these are in the rooms, in the exam rooms. A lot of times parents have seen them before I come in, but I do offer those to take home. I think what we've really learned is that the hopefully trusted voice of a child's provider, medical provider, can really make a connection with the family. So I feel the discussion in the office, and sometimes it's a discussion that will be continued over time, giving them something to take home and think about, seems to kind of continue the conversation, and maybe we'll come back to it the next time. Sometimes I'll ask kids, because you want to speak to the child also, of course, what do you think the vaccine might do for you? What are you missing? Is it baseball? Is it knowing that your school will stay open? We talk about how the vaccines protect not only the child, but it is something they do for the community. Maybe it's grandparents, maybe it's younger kids at home that can't get the vaccine yet. So we try and bring in kind of that angle as well. We do have some personal stories in our clinic. We just had a very sick 4-year-old who was at Children's for over a week with MIS-C, had a very mild initial infection. And of course, it's a small town. A lot of people, they may think they know who I'm talking about. I can't give the patient's name, but I do have the mom's permission just to share the general story that COVID is here. It is affecting kids, and it's dangerous. And so I think the personal side of, someone in our community who couldn't get vaccinated yet was really sick, I think that really resonates with people. So
thank you. If I may, I want to jump in a little bit. I see Andy and Bonnie both nodding about the experiences. It sounds like the experiences are very similar. People are asking very similar questions: trials, too fast, fertility issues, myocarditis, and I think that you hit all of those things well. But if I may add to this question, to Bonnie or Andy, what messages are you finding for your patients that are particularly resonating? And have you found that certain messengers are able to reach people more than others? And certainly feel free to piggyback on Elise's statement, but I wanted to get those questions in as well.
Yeah, it's really important. So, as an infectious disease doc, I think Bonnie and I find ourselves in the role of being the expert, and sometimes we're talking heads on TV, and where people really interact is in the doctor's office with their own pediatrician. And so I think of my role in large part as supporting the pediatricians in our region to give them the information they need and the messaging and the communication strategies that'll work. Because, I'm the doc to a couple hundred very, very sick kids in the children's hospital a year, not to the bulk of well children coming in to make decisions about vaccine. So I think there's a broader group of questions that fit into what Elise was talking about. And that is the question that parents often raise about, why does my kid need to be vaccinated? Is COVID really dangerous? I don't know anybody who's had MIS-C. And so, we do talk about the 2 million children who've been diagnosed. We talk about the 2,500 cases of MIS-C nationally. But I find it much more useful to talk about the 110 or so children with MIS-C we've seen, and within the limits of what we can do without violating confidentiality, tell some of the stories, some of the individual tragedies that we've seen, whether it's a child who was hospitalized with moderate disease who lost one or both family members while they were in the hospital and was going to go home as an orphan or without a parent. Those are the kinds of things that I think resonate. The other thing that I find resonates a lot is not so much the rare risk that your child's going to get MIS-C or even be hospitalized, but all the things that could be altered if they get post-COVID symptoms and they miss out on a year of school, they fall way behind in their schoolwork, they miss out on their sports for a long period of time, maybe lose a scholarship. And then in terms of messengers, I think we need a wide range of messengers. I think parents tend to feel most comfortable with people they know. They feel most comfortable with people who look like them. So we really try and employ as many messengers as we can, people from different communities, pediatricians and APs who work in communities that are particularly high risk. For many people, that resonates more than, the old white guy at the children's hospital.
Yeah, thank you, to Lisa and Andy for those important words. Those resonate with me as well. So one of the other things that we've seen here, I'm sure this is true elsewhere, is that I've been really involved with the studies. So obviously what was interesting with the vaccine studies is again, as I said, we thought this was a really important thing to be able to monitor and get involved with. But we did not advertise for the trials. People came to us and they were really, we had probably 10 to 20 children for every one child we could actually enroll in studies. So families were being turned away. They were just really excited. But we know that those are the people who are probably well informed and really anxious to get vaccinated. What we were worried about is what about people who are in the community who aren't getting that information? So with this, we've also been engaging in my dean's role in the Office of Community Engagement, having school town halls. I've been, really, and Lee and others, I'm sure you all have been doing these, but doing town halls with our community members, our parents in Spanish and English, working with our frontline workers at the hospital and doing one-on-one sessions with the union workers, with the frontline workers about not only their coverage, but their children, and talking about the issues that Andy and Elise brought up so well, and answering questions. And I find that in addition to telling them what they can now do that would open up their lives, I think I want addressing their specific fears, especially the ones you heard about fertility and side effects, myocarditis. When we can talk about those to individuals, just like with other vaccines, when people hear you talk to them one-on-one, I think it really does make a difference, even in a town hall format, when you're there with people, answering their individual questions and recording those and sending those out. I think that's really been fairly effective for people. I know there's still some people who are going to be hesitant, but we know that that's been true since the beginning of vaccination in general. So really focusing on the questions that we can answer for people and really not being defensive about questions, because this is a new virus and people don't know the process that we've been using for all of our careers. So that's been really helpful. And I'll just share one personal story one of my fellows' personal stories. So I was going over his 60 cases that he's personally followed in the last 18 months. And one of them was a child who the family just was not interested in. They couldn't be vaccinated. The child was also had developed some other underlying conditions over time, and they chose to get together for a family party, and the child was exposed. They were not masked, and the child wound up dying. This was a child with some underlying conditions, but being treated well. And it was just really tragic to see this. I don't like to share that with other individuals in general, but I think trying to make it personal, if it's going to help somebody understand the risks, is really important. And then the final one was when we did unblinding last week of the study, because remember the study was 2-to-1 vaccine to placebo. So we had an unblinding day. We brought in, balloons, and the kids came in and they got to hear their results. And parents sent me little videos, and they were just they were tearful and excited when their children, they found out their kids all these months later, because these were families who enrolled in June, didn't know if they'd gotten vaccine or not. So they were all so excited to be part of this. And so I think there's just a lot of heartfelt emotions on all sides, and people just wanting to know how they should respond to all this uncertainty.
Awesome. Thank you. I think what I hear is, I think Elise spoke eloquently on this, respecting people and listening, giving them the opportunity to ask questions, to share their thoughts, and really just trying to provide true, accurate information to allow them the opportunity to make the decisions for them and their families. And I found that in most instances, when you listen and really show respect to the parents and the love and care and concern that they have for their children, they typically make the decision to have their children vaccinated. The other piece I think that is extremely important, Bunny, and you spoke about this. I have seen such an excitement about families wanting to get their kids vaccinated. Here in North Carolina, we've had thousands of individuals across the state put in for appointments. And of course, we'll do other things to ensure that everyone has the opportunity to become vaccinated. But I have, been very, very happy to see across the country the number of parents who actually want to have their children vaccinated. And really, it becomes a point of access and being able to give them access for the vaccination, which really brings us to our next couple of questions. As you each represent different areas of the country, varying demographics, we know that outreach and connection are extremely important when we're talking about this vaccine and getting people vaccinated. As we think about outreach, are there vulnerable populations of kids that we may need to particularly focus on, or we know that there are vulnerable populations of kids that we need to focus on? And I think Andy kind of alluded to that during his last answer. So I'd like to do a couple of things. I'd like to talk about immunocompromised kids, and I think Bonnie, you talked about that. And I will ask Lee to speak a little bit more about immunocompromised kids. Andy, certainly feel free to jump in there if you'd like. And while they're talking about that, I'd also like to think about our rural communities, at least if you would touch on rural communities for us. And then I want us to turn and pivot to think about it through an equity lens. What about kids from historically marginalized communities? Are there specific communities we should focus on? And how can we increase trust and access to the vaccine in those communities? And Bonnie, if you would spearhead that answer. Certainly any of you could join in on those if you'd like to. But first, immunocompromised kids. Secondly, rural communities and their needs. And then third, looking through an equity lens and how we can be sure to provide access for those kids. And so, Lee, I'll turn it over to you.
Well, thank you. And I do think this is such an important question, right? I think sometimes when we talk about, when, adolescents or adults not getting the vaccine, I think sometimes we go straight to hesitancy or not wanting to get the vaccine. But I think so often there are other like real access issues. And so talking about how do we break those down as well. I think, specific to immunocompromised children, certainly they are at higher risk for severe outcomes with COVID. And Andy, I'll definitely want you to chime in on this. And so the benefit to them of the vaccine is even greater, right? But they, and at least you made this perfect point, they've also heard the same information that everybody else has, right? And some of the misinformation and some of the stuff that they feel like they need to sort through. And so I think I would do exactly as Elise noted earlier, and just really ask what their questions are and talk through those things in the way that we have all been talking about. I would also say, and I think this is probably true for children with all sorts of medical special healthcare needs, helping them to find a site, if they are to make the decision to get vaccinated, a site that they feel comfortable doing that in. I know certainly, in my own home institution at Children's National, one of the things that we decided, or the vaccine planning team decided with the rollout to the 5 to 11-year-olds is to focus initially on making sure that we were giving access to the children in our health system who have medical special needs access. And our feeling was, we know milieu well enough in DC, and there were going to be school-based clinics and opportunities to get vaccinated with your pediatrician and at some of the local pharmacies. And we wanted to make sure that for kids who might not feel as families who might not feel as comfortable bringing their kids to these sort of larger sites, that they would have somewhere to come where they did feel comfortable, where they felt like they could have their questions answered, in a place where they knew the rest of their care was being given. And so that if they were worried something, that there might be a reaction, or so that we would be there for them. And so I think thinking about that type of thing as well, how do we find this, make sure we're setting up, and I think this is the case for everybody, right? Just but making sure that we're creating opportunities for access in the places where families feel most comfortable. And Andy, I don't know, you should really add to that.
Well, I think we've probably taken a pretty similar approach for medically complex kids, whether they're immunocompromised or have inflammatory bowel disease or a rheumatologic condition or an oncologic condition. I think the other place that parents feel safe is in the place that they get their specialty care. So we've set up an outpatient vaccination clinic in the same building that we have cardiology, rheumatology, transplant, et cetera. And so that makes it easy to work with the subspecialists to sort of back up what the pediatrician is saying. Yes, you're on an immunosuppressive drug, but yeah, we also think you really ought to get vaccinated and get the whole family vaccinated. That's another little trick that we've tried to do, which is in our outpatient vaccination clinic, we've made it open to everyone, so that with any sort of luck, the oncology doc will talk the whole family, siblings and mom and dad, into getting vaccinated at the same time as the vulnerable child can get vaccinated. Success is not always what we want it to be, but it's another way of improving access.
Can I add something there too? I'm sorry, Elisa, I didn't mean to. I know you're going to talk about rural children, but I think the other area where we've been real advocates is at the federal level, with FDA, with CDC, and with the companies, to say, listen, we have an obligation to look at studies in these populations, because those are very difficult to do. And if you're under EUA, it's particularly a problem. I don't know if anybody realizes it, but if you're under EUA, emergency use, you can't use the vaccine other than what the FDA has allowed you. So you can't go off and just say, I'm going to do a study where I immunize kidney transplant patients, for example, or and then do that study, because the EUA forbids it unless FDA approves your ability to do that, and it takes some time and effort. So we need to make sure that investigators can actually pull their populations together, because we know that the immunocompromised population is very heterogeneous, and that there's going to be a very wide array of responses, and we don't have a true surrogate marker for immunity as of yet. So we need to really understand what's going on with these populations so that we can give them the information that they need. And the federal agencies need to help us do that, as well as the industry. So that's another place where we keep pushing, put the funds in, make sure we can do the work, because there are centers, all of us have centers where these studies could be done, but we're not allowed to yet. So in some situations.
So, I may ask you, I know that you really, being in a rural community, you have to deal with all of these. You have to deal with the immunocompromised. You have to deal with, and I did hear the demographics of your town, but you do have other populations that aren't just rural white citizens. So can you talk about how you, on a day-to-day basis, deal with all of those things? Because you really have seen the majority of the things that we've discussed.
Right. Yeah. Thank you. And we're 100 miles from Seattle, and we're the only pediatric clinic for our county. So we do have kids, obviously, with immunocompromised issues as well. So, but in a general basis, our rural community, I think one of the things that makes it unique is it's pretty conservative. We're in Eastern Washington, fairly conservative, fairly vaccine hesitant. Excuse me, there's actually been pushback against the statewide mask mandate. So compared to the people in Seattle, much different population. So one of the things that's a concern here is that 30% of our 12 to 17-year-olds are vaccinated. We had obviously hoped for that to be a lot higher. And our general population is 50% vaccinated. So I think we can't let go of the idea that we've got to vaccinate the adults, because it's hard to vaccinate the kids if the parents aren't vaccinated. Sometimes that happens with the older kids, but generally, so we just need to keep the adults in mind as well. And our local hospital has done a great job in terms of partnering with other organizations, Fire and Rescue Agency, the Kittitas County Public Health Department. So in our community, the hospital, the one hospital for the county, has partnered well with other agencies in terms of vaccination. So I think that's something that maybe is unique to our rural community. And it's networking. People know each other here. So these groups partner together to have mass vaccination clinics. They're doing pop-ups. There were pop-ups at the county fair, which is very big here, county fair and rodeo, pop-ups at the farmers market. And now the next step is the hospital partnering with local agencies to bring the vaccines into the schools. So several elementary schools are on board to start vaccination in the schools. So for some kids, that will be the place where they want to get vaccinated. So I think our rural communities really rely on networking and working together to promote the vaccination. And I think it's, we've done pretty well.
Thank you. Thank you. Go ahead, Andy.
Yeah. I was going to say that, when you think about the problems that rural communities face, that they're not all the same for every rural community, but they all come back to access. It may be the pediatricians' access to good information to answer questions. It may be access to a place to get your children vaccinated, because you may have to drive 50 miles to the pediatrician's office, and taking an extra trip just to get a vaccine can be difficult, particularly if it's hard to afford the gas. It may be access to information in a language you speak. I mean, when you think about rural communities in the West, they're not all white cowboys. There are a lot of Spanish-speaking populations in our rural communities. There are a lot of Black Americans in our rural communities, and some immigrants from all over the world. They have a lot more problem accessing information in their own language or with providers they feel comfortable with than they do in the city, where we have information in 15 or 20 languages and different routes of access. So it's pretty challenging. And you can't underestimate the role of politics, as Elise said. Sometimes the physicians' politics in some small towns reflect the politics of the town, and there may be a lot of distrust of federal government, of science, and we have to work against that sometimes, or not work against that, but we have to work to counter that.
I think you make great points. When you're talking about rural communities, also you have to talk about inner city communities as well, and how those individuals how their access to the vaccine is important. I think we also, particularly in rural communities, have to think about, prior to the changes of how we stored the Pfizer vaccine, it was an issue with dealing with who had the refrigeration to be able, or the freezers to be able to do it. So there are a lot of things that we have to take into consideration when we're dealing with access. But I think that you all make amazing points about access. And one of the things that we did in our community was we actually went to schools to vaccinate parents, which, hopefully we even did churches and everything to try to foster that connectivity, so that when it came time for parents to have their children vaccinated, they'd have more trust. And so it sounds like across the board, the AAP and our ID docs and our pediatricians who see patients on a regular basis are working really, really hard to make sure that we provide the access to our patients. I am interested in hearing, this pandemic has really been a learning experience for all of us, whether you take care of adults, peds, or what have you. It's been a learning experience for the entire country. And I'd be interested in hearing your key lessons learned or those takeaways. And I've heard some of them, but I'll ask you to kind of give us the elevator speech of your takeaways that can help inform our next steps to getting kids vaccinated. And I know that Elise hit the nail on the head when she talked about not forgetting the adults. There are areas in this country where adults aren't vaccinated to 60-70%. And so thank you for pointing that out. But can you give us some takeaways that you think will be helpful for us in getting kids vaccinated? I'll start with Elise, move to Andy, then to Bonnie, and then to Lee.
This has been a really humbling experience. And I think one of the things I've learned is what seems so obvious to me may not be so obvious to my families, and that a discussion should be gentle and respectful. And that's how we'll communicate about vaccines. And also that it seems that the providers, medical providers, that the family and the child trust can be an invaluable source of information and a big part of the decision making. And lastly, as I mentioned, in our rural community, I think hospitals can really successfully partner with local organizations via networking to get those vaccines out. So for me, it's been so gratifying to see that it's everybody working together for the good of the community. And I feel like that's been a vital part of what we've been doing here in our county.
Thank you.
I think Elise said it well. Everything about this pandemic has been humbling. It's been humbling to learn so much about a virus that was surprising in so many ways as it came along. It's been surprising to see how our plans for communicating and generating trust didn't always work. It's been really humbling to realize that we were not prepared for communicating in a way that would really generate trust throughout society. We can point fingers at the politics and the divisiveness of the era, but really, whatever the reasons, not being able to really reach out to people to communicate the evidence they needed to make the right decisions, whether it was about masking or vaccines or social distancing, that's been a lesson that we've learned the hard way. And hopefully we'll do better, not just in the one-on-one, but also in communicating to communities at large.
Thank you. Bonnie?
Yeah, so I'm a global health vaccinologist. I've worked in the field for 30 years now. I'm just dating myself there. And we're on the cusp. I've been working on polio eradication. We're on the cusp of eliminating polio. It took us 30 years to get to this point. So where we're almost ready to wipe out one disease, we've already wiped out smallpox. It's not easy. So the first tranche of people come in really quickly. Every single other person that you work on, people like Elise, I have so much admiration for, because every single person is a small victory. But these are issues that are historical, I would almost say biblical in nature. And we have predicted pandemics for a long time, and we had one in 2009 with the flu, but it wasn't anything like this. What it showed us is, coming back to health disparities, I think this pandemic stripped bare everything that was broken or ready to break or not well positioned in our society in general, from every single aspect you can think of. And so these were just issues that were already there. And my view is one of hope. I'm an optimist. And I think the issue is we can take all of these things and look at them and say, what was not working and how can we make it work? Because I can guarantee you we're not done here, not just with this virus, but with other future potential pandemics. And the last two things I wanted to point out is, if anybody has an opportunity to read a book by Bill Foege, who worked internationally to eradicate smallpox, he has a very easy to read book called House on Fire. And the whole point is you put out the fire. You don't start looking at the embers. You put that fire out first. We have lots of houses on fire in disparities that we have an opportunity now to address before we forget that this even happened. So I think there's a lot of exciting lessons to be learned from this tragedy. We need to learn them, and we need to move forward to make sure that if and when something else comes along, we are at least ready to start the next steps to keep our world safe and healthy.
Lee?
Well, it's always nice to be the last one to answer a question like this, because I can first say everything that everyone else said. I completely agree with it. And I think, to me, in many ways, I would sum up, I agree with Bonnie. I try to keep a hopeful lens on this. And I think our way forward is really through collaborations and partnerships and all bringing our unique perspective and skill sets together. And I think, within health, but also outside of health. And I mean, I think about some partnerships we have with the business community where we encourage businesses to give families, their employees paid days off to take their kids in to get vaccinated, right? That's a example of a partnership that substantively decreases barriers. And I think also partnerships with families and patients, because their voices are really essential in all of this. And so I think, that's something that we have all been doing and can continue to do to help move things forward.
Awesome. Thank you all very much. I am going to go to the questions. We have quite a few questions, so I'm going to pose a question to one individual and then move to the next question. If you'll give us a short, concise answer so that we can get to as many as possible, I would greatly appreciate it. The first question will go to Andy, and it's: if parents are worried about myocarditis or pericarditis risk with the vaccine, what is your answer, reassurance, suggestion? What data can I share to alleviate those concerns? And what do we know about myocarditis in the 5 to 11 year age group?
I'll try and be concise, but that's a hard one. So most important thing is that COVID is much worse for the heart than the vaccine is. 8 to 10 times as many cases of myocarditis occur if you do get infected. Secondly, myocarditis is something people should be concerned about, but it tends to be quite mild. It's quite rare, particularly in young women where it's almost non-existent. But in boys, it is something to be aware of, but the numbers are really quite low. You just have to convince people that the risk of COVID is far worse than the risk of myocarditis, and that we're going to keep a very close eye on the safety and the numbers. My best guess is that it will be much less common in 5 to 11 than in 12 to 17, based on biology and what we've seen so far. But we're going to be totally transparent about what we learn.
Awesome. Thank you. Bonnie, I'm going to pose this question to you. Many parents have concerns about the potential long-term side effects since it is a new vaccine. How can we respond to those concerns? How have the long-term effects been studied, and what is known and what is not yet known? And of course, I don't know that you could know what not yet known, but I'll pose that question to you.
Yeah, okay. Well, there's two major points here, and I'll be very brief. The first is that mRNA was discovered in 1960. So we've had 60 years with understanding mRNA itself. And in the 90s, we started doing trials with mRNA vaccine platforms in humans. And so we do have 30 years of experience with mRNA platforms already that have been extremely safe in their utilization. Now, the reason they haven't been rolled out is as you saw, it took a tremendous marshaling of resources and more importantly, money to the tune of $9 billion to get these vaccines funded to do trials. And there has not been that push to put a new platform for vaccines out for existing vaccines so far. So it's not that they don't work, it's just that the current vaccines were okay, good enough. So this has really opened up the door to using these mRNA platforms for other vaccines because they have proven to be so effective. And for the adenovirus vector vaccine, the J&J, that also has been around. It's been used in hundreds of thousands of people already in clinical trials. And for the same issue, funds and resources to do further studies in existing vaccines have not been available. So the second point then is that we do know that we'll be able to follow these up, but the FDA and the CDC have been able to look at these, particularly the FDA, to look at the safety, the potential safety signals. And as we have seen, we have the most robust surveillance systems through FDA and CDC of any country or region of the world. And we know that mRNA platforms have been extremely safe. There's no biologically plausible reason why these technologies should have major long-term effects, but just like every single other vaccine, we always track vaccines over the decades to see if there's any safety signals. And so we won't know whether there are any, but the fact is that these platforms so far have not shown any capacity for long-term effects.
Thank you. Elise, I want to pivot a little bit to you to ask this particular question. How can we convince parents who want to wait and see how other kids do? I know you've probably gotten that in your day-to-day practice. And then the other is, what strategies are being used, or what strategies are you using, or what strategies are being used by other pediatricians who are struggling with schools in their areas opting out of the mask mandate? So the wait and see versus mask mandate.
Okay, the wait and see. So actually, I was seeing patients right before this and had an ADA med check with a 7-year-old and talked to mom about COVID vaccine, and she wanted to wait and see. So I think what I tell parents is that they've already had the opportunity to wait and see, because we have thousands of kids who were studied with the standard phase 1, 2, and 3 vaccine trials, and we've seen those results. So I encourage them to go back to the standard resources and look at that data. And I also commiserate. I mean, I'm a parent too. So I think I say, if you want to do that, that's fine. I hope you don't wait too long, because in the meantime, your child is vulnerable to COVID. We have the holidays coming up. There's a little bit of sense of, let's get people vaccinated so we don't have a spike. So that's kind of my approach to it. And I do understand that. And of course, that's easier than parents who are dead set against it. So I feel like we'll get there eventually with those families. As far as, and the second question was about pediatricians dealing with people opposed to masking. Yeah, it's kind of fraught here in Eastern Washington to create a town hall situation and talk about masking and that type of thing. All I can do is support the teachers. I've offered actually to go to the schools and talk to parents about masking and vaccines. Sometimes there have been people who've been targeted when they've spoken out, medical people or health department. So I think we might be a little, I don't know how to tell people I think it's more one-on-one. So maybe going to the teachers and talking, and then offering to go to a parent council meeting. I think sometimes it's hard to be in the spotlight with something that can be fairly challenging like that. So I think that's something for everyone to decide in their community. How comfortable do they feel being in the spotlight, maybe, and talking about the importance of masking? My own way is to write articles for the paper and the hospital website, and then I can state all those things and put the information out there.
Awesome. Thank you. Lee, I'm going to ask you the final question before we wrap up. How would you make the case to parents that the need to give children the COVID vaccine is similar to the need to protect them against the other diseases we require them to get vaccinated against for school?
Yeah, I think this is such an important point, right? Because it's just this coalescing of things and intense focus on the COVID vaccines has meant that people are they're just thinking about this particular vaccine in a way that they haven't thought about others. And that is a good thing in some ways. And in some ways, it's then hard to have that perspective, I think. And so I think I talk to folks about a couple of things. I think the first thing is a reminder, right, that comparing the raw numbers of illness and death in children with adults is not really a fair comparison. Children are relatively healthy, and it is quite unusual for children to get very sick. And so when we think, and so I talk with them about that and how that is, really our goal as pediatricians is to keep healthy children healthy, and for children who have pre-existing medical conditions, keep them healthy too, right? And so I share sometimes that when you kind of cross-match COVID with other causes of death with kids, depending on how you look at the data and what sort of time frame you look at, it's in the top 5 to 10 causes of death for children in a year, and that's not insignificant. And so I think helping to think about that. I also then the last piece is I try to emphasize and remind us that really actually even one death or hospitalization that's preventable is too many, because it is. And if you were the parent of that child and your child became seriously ill or heaven forbid died from something preventable, that's unbelievably tragic. And so reminding us that for an illness that can be very serious, that is preventable through a safe and effective intervention, that's an important thing for us to do.
Thank each of you for your expertise today. It has been such a pleasure to work with you. Again, thank you to Dr. Beers, Dr. Maldonado, Dr. Herman, Dr. Pavia for joining us and sharing your expertise and insights. And thank you to all of you who joined our virtual event today. A replay of this virtual event will be posted to the AHA website later this week. Find the archive and all AHA vaccines confidence resources at aha.org/vaccine confidence. That's aha.org/vaccine confidence. Thank you again for joining us, and I wish you a wonderful rest of your day.